Good evening to all. Welcome to Ask Your Mentor program, Season 3, organized by Tamil Nadu AVO MSA. Today's topics are orthognathic surgery and distraction osteogenesis. Mentor for the session is Dr. Anush Dattich. The moderator for the session is Dr. Kadiravan. Dr. Kadiravan Selvarasu is an associate professor at Savitha Dental College and Hospital, director of Kadiravan Dental Care, Chennai. Completed his graduation and master's from SDM College of Dental Sciences and Hospital, Dharwad. He is a gold medalist and received Best Outgoing Postgraduate Award. He holds Fellowship of Indian Board of Oral Maxillofacial Surgery and Fellowship in International Congress of Oral Implantologists. Are currently pursuing PhD research at Savitha University. He has many publications in national and international journals to his credit. We welcome you, Dr. Kadiravan. May I now request Dr. Kadiravan to introduce the mentor and start the program. Dr. Kadiravan.
Yes, ma'am. Just a minute, ma'am.
Yes.
Small glitch there. 1 minute. Good evening, everyone. Is my screen shared, ma'am?
The screen is not visible. Screen is not visible.
Just a minute.
Yeah,
Now is it fine, ma'am?
it started. Yeah, it was visible.
Slideshow, please, Kadir. Slideshow.
Yes.
Perfect. Yes.
Good evening, ma'am. Thank you for the warm introduction. Let's move on to the session. And the mentor for our day is Dr. Anush Dattich. Sir is a professor and a PG guide at Pravara Institute of Medical Sciences, Loni, Maharashtra. He is a director of Dattich Clinic in Nasik. Sir completed his undergraduation in 2004 and post-graduation in 2009 from the prestigious CODS, Davangere College. Sir was awarded the fellowship in Indian Board of Oral Maxillofacial Surgery in 2014. Sir has numerous publications in national and international journals, and he has delivered scientific talks in many national and international conferences. Sir's area of interest includes orthognathic surgery, cleft craniofacial surgery, oral cancer, and reconstructive surgery. A heartiest welcome to you, sir. With this, let's move on to the session for an Ask Your Mentor session 3. The topics for the day are going to be distraction osteogenesis, and orthognathic surgery. We welcome you, sir.
Thank you very much, Dr. Kadir. Thank you, Dr. Jimson and Dr. Sasikala. Thank you very much. Pleasure to be here.
Excuse me for a small glitch there. Can we move on to the question, sir?
Yes, please.
We are starting with orthognathic surgery. The first question for the session is, what is the difference between rotating and oscillating saw used in orthognathic surgery?
Right. So the trainees need to understand that there are different tools which can be used for performing the osteotomy. Conventional handpiece and the burrs, apart from that, there is something called as oscillating saw, there's something called as piezoelectric cutting device. So these are all different types of cutting devices which can be used for performing the osteotomy. Now what we need to know is rotating burr and oscillating saw do not have the kind of control that is required to perform the given osteotomy. Now the problem with rotating saw is that there are different types of oscillating, reciprocating, sagittal cutting blades which are available with it. So oscillating saw moves the blade in a swinging motion from right to left and performs the osteotomy in the mandible or maxilla. The good thing about the oscillating saw is the cutting efficiency is much superior as compared to the conventional burrs or piezoelectric cutting device. But sometimes controlling the oscillating saw can be a difficult task, especially for the young surgeons or those who are having their hands on the oscillating saw for the first time. Right. Okay. So in the diagram, what we see very clearly is there are three different types of cutting devices which are shown. The first one is a sagittal cutting saw. The golden one down here are the piezoelectric cutting devices, and the one on the right side is the oscillating saw. Now, the difference between the sagittal oscillating saw is the motion in which the blade is working. So, the sagittal saw, the blade will be working supero-inferiorly, and it's very good for performing the sagittal cut along the anterior border of the ramus of the mandible when we are doing a surgery on the mandible, especially sagittal splitting of the ramus. The oscillating saw on the other side cuts with the blades moving from right to left. And this is very good for performing the buccal osteotomy cut or a maxillary Laporte osteotomy cut, depending on the operator's choice. My personal preference is to use piezoelectric cutting device because it has a very good efficiency in cutting as compared to the rotatory burr. The cut that is achieved with the piezoelectric cutting device is very precise. And secondly, it protects the soft tissues from getting injured. So whenever we are doing a maxillary osteotomy, and when we are working in the region of maxillary sinus, the piezoelectric cutting device prevents any injury to the maxillary sinus. At the same time, when we are performing the sagittal splitting of the ramus of the mandible, it prevents any injury to the inferior alveolar nerves and the vessels. So piezoelectric cutting device, because it spares the injury to the soft tissues, is a better cutting device. But the problem with piezoelectric cutting device is its cutting efficiency is less when it is compared to oscillating saw or a handpiece and burr. Right. So if we see the oscillating saw blade, the design is rectangular. We've already seen in the previous diagram. And there are serrations or the teeth at the end, which can be a semicircular or a straight rectangular. A reciprocating saw sometimes is also called as a wrecker saw. It is very precise and agile instrument. It can cut very quickly to the bone. And that is the reason why the surgeon who is using an oscillating saw or a reciprocating saw needs to be very careful because the cuts are achieved very fast. In comparison, so the oscillating saw is much more precise and easily maneuverable as compared to a sagittal or a reciprocating saw. Yes. So whenever we are performing bi-jaw surgery, there are two types of approaches which are described in the literature. One is a maxilla first approach, the other one is the mandible first approach. Now, in most of the centers and most of the surgeons, while performing a bi-jaw surgery, they prefer using a maxilla first approach. So a maxillary osteotomy is done, maxilla is brought to the desired position, fixed in place, and then the mandibular osteotomy is performed. However, when we plan a counterclockwise rotation of the maxillomandibular complex, that is one area where mandibular surgery is recommended to be carried out first as opposed to the maxillary surgery. Now, this counterclockwise rotation usually is indicated in cases where there is vertical maxillary excess and mandibular deficiency. So, somebody who is a skeletal class 2 with vertical maxillary excess and they also have obstructive sleep apnea. So these are the cases where we plan for a counterclockwise rotation of the maxillomandibular complex, wherein the anterior maxilla is going up, the posterior maxilla is coming down, and there will be elongation of the ramus of the mandible eventually with the bi-jaw surgery. So in those cases, performing the mandibular osteotomy first is always recommended, as opposed to the conventional bi-jaw surgeries where the maxillary osteotomy is first performed. Right. So continuing with the previous example, if there is vertical maxillary excess and mandibular deficiency, the correction would require maxillary impaction and mandibular advancement. So in correction of vertical maxillary excess, the anterior maxilla will be repositioned superiorly and the posterior maxilla will be repositioned inferiorly. And that will lead to elongation in the posterior ramus of the mandible. The point of rotation in performing this rotation of maxillomandibular complex can be at three different points. It can be along the anterior nasal spine, it can be between the premolars, and it can be at the posterior nasal spine. That depends on the surgeon's choice and the type of soft tissue profile that is being achieved in the pre-surgical plan. So for all the bi-jaw surgeries, maxilla first approach is preferred, except for the counterclockwise rotation of the maxillomandibular complex, where mandibular first approach is the recommended one. So before we talk about the maximum length of bone repositioning that can be achieved in orthognathic surgery, we must understand there is something called as relapse. And relapse is a tendency for the repositioned segments to go back to their original position. So as a general rule, what we need to understand is that it is not recommended to create more than 4 dentoalveolar segments while we are performing the orthognathic surgery in a single arch. At the same time, it is not recommended to have a single tooth osteotomy done to mobilize the CRT segment. The problem with multiple segmentation of the maxilla or mandible, or a single tooth segmentation in the maxilla or mandible, is that the penetrating blood vessels from the mandibular muscles, they are usually preserved as a result of ramus osteotomy. So subperiosteal stripping should be minimized in the posterior mandible in order to reduce the chances of relapse. Next slide. Yes. So while we are performing the interdental osteotomies, we need to understand that we should leave at least 3 to 4 millimeters of bone between the roots of the teeth, so that adequate vascularity is maintained and the denervation of the tooth is prevented. The transverse cut should always be made at least 3 to 5 millimeters away from the root apices. So when we are doing a maxillary lipo-osteotomy or a genioplasty, the cut should be made at least 5 millimeters away from the apices to maintain the vascular supply to the dental cut. The alveolar segment should be positioned equal and consistent to the vertical height among the segments to minimize the risk of postoperative periodontal pocket formation and subsequent bone loss. What we need to understand is that the risk of non-union is very high if the fixation that is applied along the osteotomy segment is not rigid enough. So all the wire fixation or a non-rigid fixation will lead to malunion or non-union along the osteotomy segments. Now, as a thumb rule, what we need to understand is that when we are performing the maxillary advancement, the maximum advancement that is recommended is not more than 6 millimeters. While we are doing a mandibular setback, the maximum amount of mandibular setback that can be safely performed is not more than 5 millimeters. So 5 millimeters of mandibular setback and 6 millimeters of maxillary advancement are usually considered as safe. Anything beyond that are associated with significantly high amount of relapse.
Okay, sir. Moving on to the next question. How much time does it take for the bioresorbable plate to resorb?
Right. So bioresorbable plates are a relatively newer kind of fixation systems which are now available in the market commercially. And the biggest advantage with these bioresorbable plates is that over a period of time, they are completely resorbed from the body with no residue left in the system. Now, what we need to understand is that most of the strength of these bioresorbable plates is retained over a period of first 10 to 14 weeks. Almost as high as 70% of the plates will remain at the end of 14 weeks. But at the end of 40 weeks, usually they undergo significant resorption, and almost 50 to 60% of the bioresorbable plates and screws, they resorb by the end of 40 weeks. But total resorption of the plates would require somewhere between 2 years to 5 years. That depends on patients to patients.
Okay, sir. Moving on to the next question, sir. What happens to the extra soft tissues after AMO procedures for retraction of maxilla?
So what we need to understand is the anterior maxillary osteotomies. They are usually indicated for anterior open bites, or they are also indicated for cases wherein there is isolated dentoalveolar excess in the anterior region of the maxilla. Can we move on to the next slide? So the usual changes which occur with the repositioning of the anterior maxillary segment is that it causes widening of the nasal bases. So there is increase in the nostril width, which can be easily corrected by performing an alar cinch suture. There is shortening of the upper lip, which can be easily corrected by performing VY type of closure in the vestibular incision. The movement of the maxilla, it leads to accentuation of the nasolabial angle. The other thing that we need to understand is that when maxilla is repositioned superiorly, it causes upturning, or the nasal tip tend to get upturned. The upper lip thickness can increase with the superior positioning of the maxilla. So different types of movement of the anterior maxilla will result in different types of soft tissue changes occurring in the upper lip, nose, and the paranasal region.
Okay, sir. Moving on to the next question, sir. During pterygoid dysjunction, is it the descending palatine artery which causes the bleeding, or is it the pterygoid plexus?
Right. So before we talk about the vessel which is causing bleeding during the pterygomaxillary disjunction, we need to understand the vascular supply of the maxillary segment, especially after performing the Lipot 1 down fracture. So if we look at the central diagram here, what it prominently tells us is that the majority of blood supply to the osteotomized maxilla is derived from the branches of descending palatine artery and the branches of nasopalatine artery. The supply is also derived from branches of ascending pharyngeal artery and the lesser palatine artery. When we speak about pterygomaxillary disjunction, the most common vessel that leads to bleeding during pterygomaxillary disjunction is the pterygoid plexus of veins. When we speak about the descending palatine arteries, the most common cause of bleeding through the descending palatine arteries is when we are performing a lateral nasal osteotomy. If the osteotomy extends beyond the greater palatine foramen, there will be brisk hemorrhage that will be encountered, and that is usually due to injury to the descending palatine vessels. So, right. So if we look at this diagram, and if we go through the literature, as a thumb rule, what we need to understand is that when we are doing a lateral nasal osteotomy, the osteotomy should be limited to 30 millimeters in female and 35 millimeters in male. Beyond this particular point, the risk of causing injury to the descending palatine artery is significantly high. However, what we also need to understand is even if there is injury to one side of descending palatine artery or bilateral descending palatine artery, the remaining vascular pedicle provides sufficient blood supply for maxilla to survive without undergoing any necrosis due to compromised vascularity. So there are different studies which are published in the literature. Turvey and Fonseca have reported that there is a risk of causing injury to the maxillary artery while performing the pterygomaxillary dysjunction. That's why what they recommend is that the curved pterygoid osteotome should always be directed inferiorly while we are performing the pterygomaxillary disjunction. So this will reduce the chances of causing any injury to maxillary artery or its terminal branches. The venous bleeding is the one which is most commonly encountered during pterygomaxillary disjunction.
Okay, sir. The next question, methods of correcting apertognathia or open bite.
So as my moderator has already told you, apertognathia basically means open bite. So there are different techniques which are described in the literature. On the screen, you can see there are different techniques which can be used for correction of apertognathia. But before we pinch onto any of the surgical procedure or before we select any particular surgical procedure for correction of apertognathia, we need to understand or we need to justify as to which jaw is responsible for this apertognathia. Now, if the deformity lies in the maxilla, there will be different types of osteotomies which will be indicated for correction. If the deformity lies in mandible, there will be different types of procedure which will be required for correction. So moving on to the maxillary osteotomies which can be used for correction. Can we move on to the next slide, Dr. Gaji?
Yes,
Yeah.
sir.
So if there is a clinical scenario where there is slight amount of apertognathia with minimum tooth exposure, minimum lip incompetency, and an adequate nasolabial angle with good anterior facial height in the lower arch, the curve of P being normal, then the indication will be performing an anterior maxillary subapical osteotomy. Now, this anterior maxillary subapical osteotomy can be either of the three procedures. It can be Weissenbaum, Wunderer, or Coupas. That depends on the personal choice of the surgeon. But maxillary osteotomy will be indicated in cases of open bite associated with minimum tooth exposure, non-lip incompetence, and cases where nasolabial angle is adequate. Similarly, if the open bite is because of the deformity lying in the mandible, so if there is accentuated curve of P, if there is transverse maxillomandibular disharmony, good aesthetic balance in the upper lip, the maxillary teeth are at normal position, so that indicates that the problem is now associated with the mandibular anterior dentoalveolar segment. And in those cases, mandibular subapical osteotomy with extrusion of the anterior mandibular segment will be indicated for correction of anterior open bite. Similarly, if the anterior open bite is secondary to bimaxillary protrusion, now those cases will be warranting a bimaxillary surgery. So anterior mandibular subapical osteotomy combined with the anterior maxillary osteotomy will be the treatment of choice for correction of apertognathia associated with bimax protrusion. Right. So yeah, if you could go back, so formulation, whenever we are doing a bijaw surgery, whether it is for correction of anterior open bite or for any other facial deformity, fabrication of interocclusal splint is very, very important to get the precise positioning of the dentoalveolar segment. The splint fabrication is key to success in performing any orthognathic surgery, even more important while performing a bijaw surgery. So there are different types of surgeries which are recommended in the mandible when we are correcting the anterior open bite. So conventional mandibular subapical surgery, apart from that, there are mandibular body osteotomies. So body osteotomies can be a V osteotomy or a Y osteotomy, depending on the type of dentofacial deformity that we are talking about. So in the diagram, what we see here is a conventional V osteotomy, where a V-shaped osteotomy cut is made in the site of the tooth extraction, and the entire anterior dentoalveolar segment is pushed superiorly. So there is something called as mandibular body sagittal splitting without any extraction of the teeth. So it is something similar to the sagittal split osteotomy, but it is used for correction of anterior open bite. So what we need to know is that the vertical bone cut is made at the same anteroposterior level, and it extends from 0.3 to 4 millimeter below the level of the root. At this point, the two lines of osteotomies are diverging. So the diverging points with the repositioning of the anterior dentoalveolar segment will become a single point of contact between the osteotomized segments. So in cases of mandibular excess along with the anterior open bite, it will require two surgical procedures. So a conventional sagittal splitting mandibular osteotomy for correction of mandibular excess, which will be clubbed with a vertical body osteotomy for correction of anterior open bite. So this is combination of sagittal splitting and body osteotomy for correction of mandibular excess associated with anterior open bite. Next slide, please. So apart from the sagittal splitting of the ramus of the mandible, inverted L osteotomy can also be used for correction of anterior open bite. But the problem with inverted L osteotomy for correction of anterior open bite is that most of the times it warrants the use of bone grafting to have adequate contact between the osteotomized segment and to reduce the chances of relapse. So inverted L osteotomy can also be used for correction of anterior open bite associated with mandibular deformities. So sagittal split ramus osteotomy, we all know, is a very versatile surgical procedure. It can be used for mandibular deficiencies, can be used for mandibular excess. At the same time, sagittal splitting of ramus osteotomy can also be used for correction of anterior open bite. So conventional cuts are made and the dentoalveolar segment is superiorly repositioned to correct the anterior open bite.
Okay, sir. With this, we are completing the orthognathic surgery session. Moving on to the next topic of this session, distraction osteogenesis. Can we move on, sir? Can you?
Yeah, please.
The first question for distraction osteogenesis. The standard protocol for distraction rate and rhythm in facial asymmetry correction patients.
Right. So when we speak of distraction osteogenesis, all the trainees need to understand that there are different stages for distraction. The first stage is a stage of osteotomy. The second stage is the latency period. Now, this latency period usually is varying from 4 days to 6 days, 7 days, depending on the age of the patient, the type of the osteotomy. Then comes the phase of distraction. Now, this phase of distraction, there are two things that we need to understand. One is the rate of distraction, the other is rhythm of distraction. So the rate of distraction usually is 1 millimeter per day. So we separate the segments 1 millimeter every day, and this separation can be achieved in different ways. Most commonly, it can be done with 1 millimeter, a single turn of distractor device causing 1 millimeter separation of the osteotomized segment, or it can be 0.5 millimeters 2 turns a day, or it can be 0.25 millimeters 4 turns a day. Most of the centers, they prefer doing 0.5 millimeters of activation 2 times a day.
Okay. Moving on to the next question. Please add a note on patient control devices for distraction osteogenesis.
Right. So what we need to know is that distraction osteogenesis is a long and lengthy procedure. So most of the times the patients have to remain indoor admitted to the hospital as long as the distraction is going on. So whenever there is deformity which warrants correction by 15 millimeters, 20 millimeters, the length of the hospital stay for the patient can significantly increase, and it can be difficult for patient to come to the hospital 2 times a day for activation. So to eliminate those the disadvantages of distraction osteogenesis, a lot of authors have come out with automated continuous mandibular distractor devices which do not require physical activation. So there are different devices which are available in the market. On the left-hand side of the screen, what we see is a device which is activated by hydrostatic pressure. So this device is the one which is activated by hydrostatic pressure. On the right-hand side of the screen, what we see is a device which is controlled by, or it is a battery-operated device. Now, the problem with these devices is that they are significantly bulky in size. they are extremely expensive when they are compared to the conventional distractors. So the biggest advantage these distractor devices provide to the operator is that they eliminate the need for prolonged stay in the hospital. But the major disadvantages of these kind of distractor devices is they are very, very expensive and they are considerably bulky when compared to conventional distractor devices.
Okay, sir. Moving on to the next question, sir. Contraction osteogenesis in maxillofacial surgery.
Right. So when we speak about distraction osteogenesis, what we need to understand is that with the distraction osteogenesis, we are increasing the length of the bone. So we are causing new bone formation. Exactly opposite to the distraction osteogenesis is the concept of contraction osteogenesis. So if we want to shorten the bone or if we want to reduce the length of the bone, then utilizing the principles of distraction osteogenesis, contraction osteogenesis can be used to reduce the length of the bone. So there are different studies which are already being published. I have just quoted one study. So what we need to know is that all the principles of distraction osteogenesis are exactly the same in contraction osteogenesis, with only one difference is that in the distraction osteogenesis, we are increasing the length, and in contraction osteogenesis, we are trying to decrease the length. Now, contraction osteogenesis, the biggest advantage or biggest indication is that it can potentially eliminate the need for extensive osteotomies for correction of deformities. So if there is significant class 3 deformity with significant mandibular excess, it might require a complex mandibular osteotomy for correction of facial deformity. So that complex osteotomy can be eliminated with the use of contraction osteogenesis. So far, there are only animal studies which are being performed for contraction osteogenesis, which are fairly successful. However, success in the human trial has not been proven so far. But I'm sure contraction osteogenesis will definitely have a good future in maxillofacial surgery.
Okay, sir. The next question. Can we do angle-to-angle reconstruction with distraction osteogenesis?
So technically speaking, angle-to-angle reconstruction with a distraction osteogenesis is possible. Now, the technique which facilitates angle-to-angle reconstruction is known as transport distraction. Now, what we need to know is transport distraction is indicated in conditions where there is a significantly large bony defect present in any of the jaws. And this defect can be secondary to an ablative surgery like mandibulectomy or aggressive curettage of large cystic lesion or a resection which is done for benign tumor of the mandible. Now, when we talk about transport distraction, what we need to understand is that planning of this distraction device and designing of the distraction device is of utmost importance for the success of transport distraction. Now, in transport distraction, the bony segment that is being transported from the donor area to the recipient area is called as transport segment. Now, if we look at this diagram, this segment here is known as the transport segment. And this segment is going to move along the arc of this distractor device, and it will form new bone all throughout the arc. And eventually it will go and meet this segment on the other side of the mandible, which is known as the docking segment. So transport distraction can be utilized for creation of or correction of segmental defects of maxilla and mandible. And technically speaking, it can be used for correction of mandibular defect extending from molar to molar. But the most important and most challenging aspect of utilization of transport distraction is to ensure the vascularity and maintaining the intact distraction chamber or soft tissue envelope. Maintaining the vascularity and soft tissue envelope, if it is not done correctly, it will lead to significant resorption of the distraction chamber, and it will create a defect which is significantly larger than the defect from where we started.
Okay, sir. Moving on to the next question, sir. What are the differences that we face in the distraction of maxilla versus mandible?
Right. So technically speaking, whether we are performing distraction in the maxilla or we are performing distraction in the mandible, there are no difference in the technique. So the principles of distraction for maxillary surgery, principles of distraction in the mandibular surgery are essentially the same. However, because the nature of maxillary bone and the nature of mandibular bone is different, there are certain differences in the distraction procedure in both the jaws. So what we know very well is maxilla is more cancellous bone as compared to mandible. And that is the reason why amount of latency period in the maxilla can be lesser as compared to latency period in the mandible. Similarly, because mandible is more dense in nature as compared to maxilla, so the consolidation period or maturation period required for a mandibular bone can be much more as compared to that of the maxillary bone. We also need to understand that the muscular attachment in the mandible is much stronger as compared to muscular attachment in the maxilla. And that is the reason why, to prevent the chances of relapse, the need for longer consolidation period in mandibular distraction is much more necessary as compared to that of the maxillary distraction. So distraction in maxilla and mandible essentially is the same, but maxillary distraction has a lesser latency period, lesser period of consolidation as compared to that of the mandible because of the type of nature of the bone which is present in maxilla and mandible. And because of the strong muscular attachment, the chances of relapse in the mandibular distraction are much higher, which warrants the need for significantly longer consolidation period as compared to that of maxilla.
Okay, sir. Thank you. Moving on to the next question, sir. What are the differences we face in a distraction performed for a pediatric age group versus an adult?
Right. So similar to the difference between the maxilla and the mandible, there is not much different in the technique or principles of distraction in pediatric patient versus adult patients. But what you need to understand is that in pediatric patient, because the osteogenic potential is much more, because the rate of turnover of the cells is much higher, the duration of latency period in pediatric patients is significantly lower, anywhere between 3 days to 5 days. At the same time, the latency period in the adult distraction cases can be anywhere between 5 days to 7 days. Similarly, because of the higher turnover of the cells, the consolidation period in the pediatric patient is significantly lower as compared to that of adult patients. But what we also need to understand is that in pediatric patient, the height and the width of the bone is significantly lesser as compared to that of adult patients. And that is the reason why fixation of distraction device can be little difficult in pediatric patient. That is the very reason why external distractors or pin distractors are preferred in pediatric patient as opposed to internal distractor or intraoral distractor, which can be very well used in adult patients. The myofunctional appliances which are given to the pediatric patient for correction of facial deformity essentially works on the principle of distraction osteogenesis, wherein it causes selective growth in a particular area which can be utilized for correction of facial deformities.
Great. Moving on to the next question, sir. What is orthomorphic distraction?
So orthomorphic distraction is a relatively new concept which is proposed by Dr. Bandikandan sir. And this essentially is something similar to orthomorphic surgery, which was originally described by Dr. Paul Salins. If you could move on to the next. Yes. So orthomorphic distraction revolves around the concept of orthomorphic correction for facial deformity, secondary to temporomandibular joint ankylosis or hemifacial microsomia, which was originally described by Dr. Paul Salins. So orthomorphic surgery, if we try to understand this diagram, if there is ankylosis of this side of mandible, leading to shortening of the ramus, shortening of the body of the mandible, the other side essentially is growing normally. But because this side is not growing, the entire mandibular segment and entire chin segment is shifted towards the ipsilateral side. Now, this correction would necessitate rotation of the mandibular segment and the chin segment for correction of facial deformity. And this can very well be achieved by orthomorphic correction. Now, the problem with orthomorphic surgery is that when we rotate the mandibular segment for correction of hollowness that is present on the normal side, it requires bone grafting so as to prevent any relapse and so as to maintain adequate contact between the bony segments. Now, to overcome the disadvantages of orthomorphic surgery, that is higher rates of relapse, and need for bone grafting between the osteotomized segment, orthomorphic distraction was proposed. Now, the major advantages of orthomorphic distraction is that it provides aesthetic correction as well as correction of sleep apneas associated with temporomandibular joint ankylosis. It avoids the need for any end-to-end bone grafting. Because of the distraction, there is new bone formation between the osteotomized segments. And because there is new bone formation in the osteotomized segments, the chances of relapse are significantly lower as compared to orthomorphic segments.
Okay. Moving on to the next question, sir. Can simultaneous maxillomandibular distraction can be done, and what are the indications and techniques involved for it?
Right. So simultaneous maxillomandibular distraction can very well be done, and it is indicated in certain conditions, especially in cases where there is shortening of the mandibular ramus and subsequent vertical maxillary hypoplasia on the ipsilateral side. Now, this kind of deformity is very commonly seen in patients with hemifacial microsomia or Goldenrod syndrome. Can also be seen in patients with condylar aplasia, hypoplasia, or condylar agenesis. Now, what is happening here is that the schematic diagram, what you see is there is vertical deficiency of ramus on the right side. And that subsequently leads to vertical deficiency of the maxilla on the right side. Now, because this vertical deficiency is from birth, patient has good occlusion, but there is occlusal canting. Now, this is a case that I had operated about 5-6 years back. If you see very carefully, there is shortening of the ramus on the left side, and the right side ramus is normal in height. And subsequent to ramus shortening on the left hand side, there is shortening of the maxillary dentoalveolar segment on the left side as compared to that of the right side. And this shortening of the left side leads to occlusal canting. Now, this canting can very well be corrected by performing a simultaneous maxillomandibular distraction. Now, this simultaneous maxillomandibular distraction requires a leopard osteotomy for maxilla and a horizontal ramus osteotomy along the ramus of the mandible. Now, in the first diagram, what you see here is this is the conventional leopard osteotomy. And on the second diagram, what you see is that we've done a horizontal ramus osteotomy and the distractor is fixed in the mandible. Now, after fixation of the distractor, a small plate is fixed on the contralateral maxillary buttress so as to prevent any distraction from happening on the contralateral side. And maxilla and mandible are placed into intermaxillary fixation. And after 5 days of latency period, the distractor device is activated. Now, this distractor device causes increase in the length of the ramus. And because the maxilla and mandible are in intermaxillary fixation, it eventually causes increase in the length of the maxillary dentoalveolar segment as well. Now, what we see in this orthopantomogram very clearly is the ramal shortening on the left-hand side as compared to right-hand side. And at the end of distraction, we've almost achieved about 16 millimeters of gain in the ramus length and subsequently correction of the occlusal cant as compared to the preoperative occlusal cant. Now, the major advantages of doing a simultaneous maxillomandibular distraction is that it brings about a simultaneous correction in the maxillary as well as mandibular dentoalveolar segments. It avoids any need of bone grafting because we are increasing the length of maxilla as well as mandible by distraction, so it does not require any bone grafting, and it does not alter the dental occlusion because we are constantly keeping patient into intermaxillary fixation, so the occlusion remains essentially the same from where we started. So these are major advantages of simultaneous maxillomandibular distraction.
Thank you. Okay, sir.
Right. So these are the references which I would recommend all the trainees to read. Very important for you all to know about the details of distraction osteogenesis because there are a lot of questions which will be asked pertaining to distraction osteogenesis in theory as well as in vivos.
Thank you, sir. Thank you very much for the in-depth lecture on distraction osteogenesis and orthognathic surgery. Thank you for your valuable insights. And thank you all the audience for your patient listening all this while. From here, I'll pass it on to Dr. Kalpa.
Thank you.
Thank you, sir. With this, we come to an end to today's session. On behalf of Tamil Nadu AMSI, we would like to extend our heartfelt gratitude to Dr. Anuj and Dr. Kadiravan for their valuable time and sharing of knowledge. Now the participants are requested to stay connected to fill in the Google feedback form that is posted in the chat box. Filling this is mandatory for your certificates. You'll get about 10 minutes to fill in the feedback form. Once again, thank you, Dr. Anuj, sir, and Kadiravan, sir,
Thank you, Kalpa.
for your time. Yes, sir.
Thank you.
Thank you, Anuj, sir.
Thank you, sir. Thank you.
Anuj, sir, and Kadiravan, sir, this will take about 10 minutes. So if you have any other work, you all may leave the session, sir.
Sure. So we'll take the questions after the forms you filled up.
No, so the chat box questions will be addressed in the last session.
Okay.
In the feedback form, the students will be filling in some answers. That's different.
Okay.
So in this session, we will not be taking up the questions.
Sure. Thank you.
Yes.
Thank you, Kalpa.
Thank you, sir.